Thank you, David. And David posed the question, he didn't know why Governor Jindal didn't accept the money from, well, the Affordable Care Act, more frequently known as the Obamacare. So we'll ask Calder Lynch to explain that.
Thank you, Gene, and thanks, David. It's good to see you. David and I actually agree on a lot of things with regard to some of the problems in terms of what we didn't address in healthcare reform through the Affordable Care Act in terms of cost containment measures. I mean, that was really one of the biggest disappointments, as he highlighted at the end of his introductory remarks, is that our nation spends more per capita on healthcare than almost any other industrialized country. And yet our debate over this entire period has been about coverage and not cost. And certainly coverage is an important component of that, but until you address the cost issues, you're really just creating a recipe for more costs and more debt. And speaking of coverage, he highlighted the success we've had with our children's health insurance program and in our Medicaid program, and it has truly been a success. Now having less than 3% of our children in this country uninsured. In fact, one of the first things Governor Jindal did when he took office in 2008 was expand that program, as he mentioned, as covering kids was a priority. We do now have achieved that level of coverage, and that really is a great thing. In terms of the discussion about the Affordable Care Act and the Medicaid program, when the law was passed, as we all know, there were many different components to it. It was a very lengthy and comprehensive piece of legislation that everyone had to spend a lot of time trying to figure out. And one of the things it did do was originally mandated that states expand their Medicaid programs to cover what was really considered a newly eligible population of childless adults. These are adults that didn't have children, up to what they defined at 138% of the federal poverty level. In Louisiana and in most states, that's a population that isn't covered at all in Medicaid, or if it is, it's covered on a limited basis, more limited benefits, et cetera. And what they did is they said states, if you don't expand to that level, you're going to lose all your federal Medicaid money. And the Supreme Court ruled, said, no, you really can't do that. You can't force states to enroll a new population and threaten the financing for their existing program. So many states have now decided that expanding their Medicaid programs wasn't the right solution for their state, including Louisiana. And when you look at the reasons why we made that decision, there are many. Today, Louisiana Medicaid covers about 29% of our population. That's one of the highest in the country. For states that are expanding Medicaid, the vast majority of them are looking at bringing over 30 of them. Their Medicaid programs, as a percentage of their state's population, would be at or below where Louisiana is today after an expansion. If we were to expand, we would have somewhere between 41 and 43% of our state's population enrolled in Medicaid, which would be the second highest in the country. When we did our analysis, we saw that it would eventually extend full Medicaid eligibility to as many as 650,000 individuals in Louisiana. That is 2 to 3 times the number of individuals that will remain uninsured after implementation of the Affordable Care Act, which is really an overreach, because what you end up doing is carving about 250,000 people out of the private insurance market by expanding that eligibility. About 171,000 of those individuals have private coverage today that would then become eligible for Medicaid, and that's the portion we estimate would actually move over to Medicaid, where they have very limited co-payments, no premiums, et cetera. And also another 77,000 individuals that are eligible for private insurance in the new exchanges, but that would be forced into Medicaid by virtue of the new eligibility levels if we expanded. So you're talking about 250,000 fewer people in the private insurance market, 2 to 3 times the number of individuals coming into Medicaid that are really going to remain uninsured after the implementation of this law. And from our estimates, a cost to the state of up to $7 billion over 10 years in new state funds. And the reason that figure is so high is because there's so many unknowns whenever you bring that large of your population into your Medicaid program. Today in Medicaid, we cover prominently children. It's very few adults unless they have disabilities, or a very small segment of parents and caretakers. That our provider networks are already strained with the populations we have today. We've made great progress in that regard with implementation of our managed care program, Bayou Health, but still it's a program that serves predominantly children. So by bringing in, as many as over 500,000 new adults into the program, there's questions of whether the provider network we have today is really able to handle that sort of influx. And what that would do is put enormous pressure on the state to increase our reimbursement rates in order to recruit new providers into the program. And in fact, one of the provisions of the Affordable Care Act actually says that states are now required to ensure that individuals in Medicaid have access to medical services. So we could face legal action that would require us to raise those reimbursement rates. And while the federal funds for the Medicaid expansion program are enhanced, at least for now, we would have to raise those rates for everybody. And over 10 years, that could cost us over $7 billion. The last part I'll say is that, for this remaining group of population, which is anywhere between, we estimate about 214,000 and 250,000, some groups estimate, we think it's a little high, that will remain uninsured. We have a robust safety net in our state that's growing stronger through the use of public-private partnerships with LSU. We've already seen, as the governor highlighted earlier this week, in 2 stops in Lake Charles and Houma, new clinics that are reopening, new services that are reopening. Here in Baton Rouge, as part of the partnership between LSU and Our Lady of the Lake, a new urgent care center, 24 hours a day, has opened in North Baton Rouge. We have in Houma, they've added a new cardiologist that in the first month has already treated 60 patients, a new urologist, new equipment that is serving over 200 patients, new mammography equipment that is serving those individuals. And in Lake Charles, we're seeing new clinics, orthopedic, breast health, gastroenterological, and cardiology clinics have opened, and we expect that progress to continue across the rest of the state that is enhancing access for those individuals that will remain uninsured. Thank you.
Viewpoint from the Department of Health and Hospitals. Now we're going to hear from the Department of Insurance, and this, I will have to say that the Speaker of the House, Chuck Cleckley, wisely looked at our platform and said, you're missing a component. Let me get the Department of Insurance to take my place because they're more knowledgeable on an area that we had missed. So would you please come forward? Corey, would you welcome Corey Harvey?
Thank you. I'm going to steer clear of the Medicaid expansion debate. I might be something of the odd man out, and the reason is because what I always like to explain to people when we talk about the Affordable Care Act, I'm going to say Obamacare because it's shorter, and the president says it, so it's clearly not a problem. So the thing about Obamacare is that it is probably one of the largest regulatory acts passed by Congress in really quite a few decades. And even after the Enron scandal and other scandals like that, there hasn't been any kind of act of Congress that has so dramatically changed the way that business in a single industry works. And when we hear public debates about Obamacare, we hear about Medicaid expansions, we hear about the individual mandate, we hear about the employer mandate, but the problems with the exchanges, but what we don't really hear about are the substantive provisions of the law that really have a lot to do with what you're hearing about with rate shock. Depending, for some people it hasn't been too much of an increase, but some people are experiencing pretty dramatic increases in the cost of their health insurance. And what I like to tell people about is why that's happening. And that's happening because in Obamacare, there are substantive provisions of the law that mandate that your health insurance coverage covers certain things. There are categories of benefits and services that you simply must pay for in your policy. You don't have a choice about it. And beyond that, there are those 10 categories of benefits. There can't be any annual limits on what your insurer spends on those benefits. And for years, if you had a covered benefit in your insurance policy, there was frequently some kind of amount of money that the insurer would pay no more than that. And all of those limits are gone. So that has to be factored into the risk. It has to be factored into your premium. So those kinds of things will drive up the cost of your health insurance. Bigger than that, we see in the law a ban on medical underwriting. And for years, if you were an unhealthy person and you went to get health insurance coverage from an insurer, that would have a direct effect on what your premium was. Well, starting in 2014, as long as you're not on a grandfathered plan, that can't happen anymore. So if an insurance company can't avoid risk or manage risk, what it has to do is spread the risk out. So if you are a younger person, you're going to be paying more than you would have been paying a year ago. Or if you're a healthier person, you're going to end up paying more than you would just a year ago. So all of these substantive provisions of the law had a direct effect on why insurance rates go up. In addition to that, there were a category of benefits called preventive services that have to be covered in your insurance policies, and for many of them, there's no fee. You can't be charged a copay or co-insurance whenever you go to the doctor for those preventive services. Well, I think we all know that there's no such thing as a free medical service. So all of these things are factored into your premium. You don't really have much of a choice about it. And the reason I wanted to talk about this area is because Gene had mentioned the move to defund Obamacare, and what did that really mean? And to me, I read the amendment to the continuing resolution that didn't pass, but what it would have done simply was cut off the money that the Department of Health and Human Services in Washington has to spend on Obamacare enforcement, and would have stopped payments out of the Treasury under the law under Obamacare. And part of the fix that whoever, the policymakers who came up with Obamacare, part of the fix that they came up with was that there were certain programs that would be established that would try to stabilize the insurance markets, because some of these changes are so dramatic and we don't know exactly what the effects would be. And frankly, if you were to cut off these programs, like there's a reinsurance program to help insurance companies that end up with a lot of bad risk and they can't avoid the risk, so how do they stay solvent? There's also risk adjustment programs where if one company ends up with a lot of really good risk and one company ends up with a bad risk, well, the company that ended up with a lot of the good risk is going to have to make payments to their competitor who ended up with some of the bad risk. And frankly, if you simply just cut off those programs, I think that there's a chance you could destabilize that market. So I think the point I'm trying to make about the defunding is, if you don't like the law, you're going to have to change it substantively. Simply cutting off the flow of money might have the effect of destabilizing the market. Gene also asked me to address the prescription donut hole in the Medicare Part D, and thankfully I don't deal with that very much because it's a federal program, and I mean, it's a serious problem, and I think Congress and HHS has tried to they're taking steps to eliminate that hole by, I think, 2020, which is, I know, a long time from now. And also in the Affordable Care Act, there was a provision that allows that essentially it ends up being, I think, a $250 annual payment to people who fall into that hole. Obviously, that doesn't do a whole lot, but thankfully, there's nothing I'm expected at the Department of Insurance to do about it, because I don't know how to fix that problem.